Okay. Anyway, so I have started the recording. Let's continue. So, what all features would you look for to find out if it's a malignancy? And you've answered about hypoechogenicity, microcalcifications, absence of peripheral halo, irregular borders, solid aspect, uh, intranodular blood flow, and shape, which is taller, more than wide. These are the features. These are the ultrasound features that are associated with malignancy. So you have rightly said that these features would give you an idea if you should go ahead with FNSE, if it is at all a malignancy. So, FNSE for the question I was asking is that when should FNSE be performed? And the answer, correct answer would be, it would be performed for thyroid nodule, for all thyroid nodules more than 1 centimeter.
Yes.
And those thyroid nodules less than 1 centimeter, we should do it if there is any clinical, like if there is any history of radiation to the neck, head or neck, or if there is a family history of thyroid cancer, suspicious features of palpitations, features at palpation or presence of in any lymphadenopathy. So these are the 4 features. If the lesion is less than 1 centimeter, or for all lesions more than 1 centimeter, you should do an FNSA, right?
Yes, sir.
Okay. So after that, would you like to do any kind of any kind of in any other test, any nuclear medicine test for the workup, to proceed with the workup?
So we might do a radioactive iodine uptake, but not here actually. First of all, FNAC would have established the type of cancer, and based on that, we'll do further investigation. I'm not sure of any nuclear medicine study at this level, sir.
Right. So the takeaway message is that you are not like it's not usually not indicated
Yes.
upfront. So radioactive iodine
Post-surgery.
studies are required, but not at this stage.
Yes.
So is there anything else that you would like to test for? Like it's not mandatory, but is there anything else that at this point of time you would like to look at?
So evaluation of vocal cord mobility needs to be done. It can be considered at this stage.
Yes, so you would do an ideal and evaluate if the vocal cord is mobile. Why do you need to see if the vocal cord is mobile?
So because we, for the management, will do a surgical management, and the most common complication is a recurrent laryngeal nerve palsy. So to have the baseline idea, and for further process, we need to know.
Yeah, so if it's a thyroid cancer, at some point of time, you're going to go ahead and do a thyroidectomy. So whenever we're doing a thyroidectomy, the injury to the recurrent laryngeal nerve is very much common. So more than so it is also important as far as medical legal issues are concerned, to have an baseline idea of what the uh, uh, status of vocal cord right now is. So there can be an unilateral palsy, and after doing so it won't be if it's a unilateral palsy, it won't be having any symptoms as such. Once you're doing it, you're also injuring the contralateral vocal cord. Patient might lose his voice. So if there is one such if there is any baseline policy or not, you need to discuss that with the patients in details. Okay, let's go ahead. Is there anything else that you would look, or would you go ahead with surgery after that?
So for medullary thyroid cancer subtype, we need to do some additional tests, such as basal serum calcitonin, pheochromocytoma screening can also be done, germline red proto-oncogene mutation, these also need to be seen.
Okay,
and
so yeah, go on.
For anaplastic variety, additionally, we need to do a FDG PET-CT and a bronchoscopy if airway invasion is present.
Right.
And apart from that, for pre-surgical planning, a CT or MRI needs to be done as well, sir.
CT or MRI needs to be done to assess the
extent of extraglandular tumor involvement, and the need for any neck dissection or not.
Right. So first thing is that there are various guidelines regarding neck dissections. Some guidelines say that you should go ahead and do a prophylactic neck dissection, and that too there are types of neck dissection that you need to consider. I'll be coming to that later on and throughout the course of this discussion. But the thing to understand is that you need to find out if there is any local if there is any local regional extent to find out the local regional extent of the disease.
Yes,
So if there are lymph node metastasis and if there is extra thyroid extension of the disease.
yes, sir.
Okay, so that would give us various risk factors, and you would go ahead with surgery. The point that I was trying to stress upon was you mentioned it rightly. So the point is molecular markers. Even though at this point of time it doesn't have much importance, but there are some molecular markers which would give us some idea about the type of disease that is. So BRAF mutation would give us would point us towards the diagnosis of a papillary thyroid carcinoma uh, over follicular type. And then there is obviously the RET mutation, or if you can do find out if there is any RAS mutation or any other PAX8 or PPAR gamma mutations, etc. Most important is the BRAF mutation, which would point you towards the diagnosis of a papillary thyroid carcinoma over follicular. Fine. After that, you have done that, and then you want to go ahead with surgery. How would you
Yes.
decide if you want to go for? So, what surgery would you do?
So total thyroidectomy, especially in papillary and medullary variant.
Right. Okay.
And for follicular, lobectomy and isthmusectomy may suffice. But in case there is invasive disease or metastatic disease, in that case, total thyroidectomy needs to be done.
So, would you like to do a partial thyroidectomy for that matter in any case? If you're saying for total thyroidectomy, so is there any indication of, not indication per se, but are there any cases where you would go ahead with partial thyroid removal?
So I can't recall off actually.
Okay, so you need to see some of the risk factors. Although if like there is no such indication for doing a lobectomy, but if all of the following are present, you might consider doing a lobectomy or isthmusectomy. And so these are the following. You can note it down. So if the patient doesn't have any prior history of receiving radiation, there are no distal metastasis. There is no. This is mainly for papillary carcinoma. Can also be considered for follicular carcinoma. So, no prior RT, no distant Mets, CN0. So no nodal Mets on CT or MRI. No extrathyroid extension, and the tumor should be within less than equal to 4 centimeters. See, if all these criteria are present according to the NCCN guideline, you may consider doing a lobectomy. Other than that, a thyroidectomy is a total thyroidectomy is a good enough options, especially if any of the cases are positive. So if the patient is having a distal metastasis, or extrathyroid extension, or if it's a more than 4 centimeter size lesion, if there are any lymph node metastasis, if it is poorly differentiated, if there is any history of prior radiotherapy, or if there are bilateral nodularity if you can see in the thyroid gland, then obviously have to go for a total thyroidectomy,
Yes, sir.
right?
Yes, sir.
In case you have done a lobectomy or isthmusectomy, you again need to look at the histopathological the histopathology report. So even if in the histopathology report you see that the margins are positive, or if there is a extra thyroid extension, if the tumor is more than 4 centimeter, or if there is a contralateral disease, or you can see vascular invasion or poorly differentiated carcinoma, you have to anyway go ahead and do a completion surgery, which is basically removing the entirety of the thyroid. So if none of these are positive, so if your report comes as margin negative, no contralateral lesion, less than 1 centimeter lesion, and no suspicious lymph node, then only you can leave it at that. You can just uh, your treatment would get completed at uh, uh, a partial thyroid removal. So you have done that. You have done a total thyroidectomy. So what would you look at to decide any further course of action?
So here we need to see if there is any residual thyroid tissue or not, and for that we can do a radioactive uptake test, and based on that, further therapy will be given.
Right. So others can unmute yourself and ask questions. Ask me to repeat if you are not getting anything. I will repeat. So please feel free to ask questions. Just unmute yourself and ask questions, because I'm not able to switch on the screen sharing. So I'm not noting it down. We're just discussing it over voice. So please feel free to unmute yourself and ask questions. At this point of time, I would like to ask you, do you think there are any indications of external beam radiotherapy in thyroid cancer? Is there so you have a thyroid lesion, you have uh, done the surgery, and do you think there are any indications for doing an external beam radiotherapy?
So not at this stage, I believe.
Any one positive, we have to go, Dr. Kanam, anyone positive, we have to go for thyroidectomy. Yes, any the cases, the condition that I mentioned, like distant metastasis, extrathyroid extension, tumor more than 4 centimeter, lymph node positive, poorly differentiated, prior RT, bilateral disease. So any one of these is positive, we have to do a total thyroidectomy. Only if all of the cases are negative, like no prior RT, no distant metastasis, CN0, no extrathyroid extension, less than 4 centimeter. If all of them are negative, then only we can consider lobectomy. But still, a total thyroidectomy is still indicated in those cases, but you can consider doing a lobectomy. As far as Ebrt was concerned, yes, there are some indications of doing. Yes, Ebrt can be considered for
Excuse me,
anaplastic
sir.
carcinoma. Yeah.
So the size criteria, is it 4 centimeter or 1 centimeter? Because in NCCN, I think it is 4, and in ATA American guidelines, is it 1 centimeter? 2009.
Right. So NCCN gives both. Okay, NCCN says that if it is less than 1 centimeter, then you can definitely go ahead for. So NCCN also follows the ATA guideline. And NCCN at many places also gives reference to the ATA guideline. So it is, if it is more than 4 centimeter, definitely you have to go for uh, 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 a total thyroidectomy. But anything less than 4 centimeter, if 1 to 4 centimeter, you may consider, and one less than 1 centimeter, you can safely go for a lobectomy. So so you can. The point is that if it is more than 4 centimeter, then definitely total thyroidectomy. Less than 4 centimeter, you may consider a lobectomy.
Okay, sir. Thank you.
So should age be considered for partial thyroidectomy, sir?
For would you consider age for partial thyroidectomy? No,
Yes, sir.
no, I don't think age is one of the criteria that you should consider for partial thyroidectomy. Not according to NCCN, at least. Right? Any other doubts?
Okay, sir.
Can someone?
Yeah. One more thing, like you were asking about this thing, like only where we'll give only Ebrt. So maybe like in a medullary CA thyroid where like we can't give iodine ablation. In those cases, if it's a if there is recurrence after surgery, then there are a few studies which says that we can give EBRT in medullary CA thyroid.
Yes. So my question was, what all are the indications for EBRT? So not just afferent EBRT or adjuvant EBRT. And you are right, medullary thyroid carcinoma is one of the conditions where you would go for EBRT. So even someone said anaplastic carcinoma, even anaplastic carcinoma, we can consider doing an EBRT, but we would come to anaplastic carcinoma later. Uh, uh, so for differentiated thyroid carcinoma, especially papillary carcinoma and follicular carcinoma, can someone mention what are the indications you can think of for doing EBRT?
So unresectable disease or gross local invasion with residual disease, and in a recurrent neck disease, not amenable to surgery.
Yeah. So at this point of time, like we're discussing from the beginning, at this point of time, if the patient is more than 45-year-old with gross extrathyroid extension and are high risk of having a microscopic residual disease, patient should be considered for an EBRT. Also, if for all non, like Udipto said, for non iodine avid diseases, okay, those cannot be treated by doing a RAI ablation. Not just failed RAI ablation, but for cases like medullary thyroid carcinoma that has been diagnosed, that has been confirmed on a, if it is confirmed on a histopathology. So we know that for a medullary thyroid carcinoma, it won't respond to RAI at all. So for all those cases, we would like to go for EBRT, and those patients who are having gross extracapsular extension. Right. So do you want me to repeat the indications for EBRT?
Yes, sir.
Yes, sir.
Sir, there was a doubt. We will go for upfront EBRT or we will wait for adjuvant EBRT?
No. See, the thing is that once you are done, once we are, the first thing is that you have to go for a surgery, right? If it's afferent EBRT, means the case is very advanced and you're just trying to do a palliative therapy. So this is not afferent EBRT. This is after doing a surgery. If there is a gross extracapsular extension, so you have found that the margins, like the margins are positive, and like you and the patient has. Yeah. So what I was talking about was the indications for an adjuvant. So even in afferent cases, there are evident there afferent inoperable cases also we are indicated, radiation is indicated. But I'm talking about adjuvant. So patients who have a gross residual disease in the neck, those are the patients you would go for EBRT. And especially if the gross residual is unresectable. So if the gross residual disease is unresectable, you would like to go for EBRT, and for those patients who are having disease that are not iodine avid, right? So these are the only two indications if you simplify it in that way. Other than those patients who are not having who are having an inoperable thyroid cancer, other than those who have for whom you have done a thyroidectomy, if the patient is having a gross residual, you need to see if the gross residual is resectable or not. So even if only if the gross residual is not resectable, you are supposed to go ahead and do an external beam radiotherapy. Am I clear?
Yes, sir.
Yes, sir.
Okay. So So moving ahead, you have done the thyroid. You have done a total thyroidectomy, and what do you do next after that? Anyone? Would you like to give any medications after doing a total thyroidectomy?
Sir, hello.
Thyroxine.
Yeah,
Hi.
you're audible. Please answer.
After her total thyroidectomy, I would like to start her on replacement doses of thyroxine until she has been until she is below her serum TSH levels are below 0.1 microgram.
Why would you like to keep the serum TSH level low?
Because these are well differentiated cancers and it's
For suppression of the normal remaining, if there is any tissue, to suppress the thyroid.
So yeah, it was seen that even TSH itself is a causes multiplication of the tumor cells. So keeping a TSH level low would help you with the uh, keeping the disease volume low. So you would like to go ahead with levothyroxine to keep TSH low or normal after doing a after doing a thyroidectomy. When would you consider if RAI is recommended in that case patient or not?
So 2 to 4 weeks prior the RAI, we will stop thyroxine, and we will maintain the patient on low iodine diet.
Then?
So that the TSH is increased and the iodine, when the radioactive iodine is given, it is maximally uptaken into the cancer cells.
No, that is, yeah, right. Can you please repeat? I missed it. Can you repeat what you're saying?
Sir, we will give levothyroxine, but if we want to start radioactive iodine therapy, we will stop it before 2 to 4 weeks, so that the TSH level is increased, so that the iodine that we give is maximally taken up by the cancer cells.
Yes, that what you're saying is if you decide to go for an RAI, you need the cancer cells to be hungry for iodine, right? So if you are giving an iodine, if you're giving a radioactive iodine, the cancer cells are supposed to be hungry for iodine so that they can take up that iodine, and then the iodine can start the radioactive iodine can start killing the cells. So for that reason, you need to keep the TSH level high, and you need to keep the TSH level high, and you need to keep the patient on a very low iodine diet. But I'm not talking about that. I'm saying how do you decide if the patient needs a radioactive iodine at all?
Sir, we should be checking. Her post-operative serum TSH values should guide her whether she requires a diagnostic iodine scan or not. If we have not attained suppressive levels of serum TSH has not reached levels, you can think of going for a post-operative iodine scan, diagnostic iodine scan.
Okay, so there are some specific indications in which you would like to go for a post-operative iodine scan, and if you are finding out that the patients are having, if you find out that the patients are having, just 1 second, to meet all.
Yes, sir. It is if the stage is T3N0 and if the age is more than 55 years.
Excuse me, sir is not audible. Excuse me, sir, you're not audible.
Hello.
Hello.
Yeah, I'm sorry. I kept on. Okay, sorry. So I'm talking. So I was saying that RAI is not indicated in all RAI. There are some specific indications where you should
Yes, sir.
consider
That is
doing an
ATA guidelines are there, sir. That is T3, M0 tumor with if the age is more than 55, or if the patient is having extra thyroidal extension, or if node is positive, then we have to think about RAS in this patients.
Right. So various guidelines give various indications for doing an RAI. Basic concept is that the basic concept is if the patient is having a residual thyroid tissue in the body even after doing a complete thyroid excision, if the patient is having residual thyroid cancer, residual thyroid tissue in the body, cancer tissue obviously, then only you're supposed to go ahead with an RAI, so that whatever remnant thyroid tissues are there, that can be ablated. Okay, so so it is also known as remnant ablative therapy for the same reason. So how do you know if there are remnant tissues? For that, you need to. There are some other surrogate markers, like if there is a gross extrathyroid extension in the histopathology, obviously there would be remnant tissues. Some high risk of remnant subclinical disease would be if the primary tumor is more than 4 centimeter. If it's a bulky or more than 5 positive lymph nodes on lymph node dissection, then also you would consider doing an RAI. And if the post-operative unstimulated thyroglobulin level is more than 5 to 10 nanogram per ml. Okay, and other indications would include like cervical lymph node metastasis. If it's a multifocal disease with any of the focus more than 1 centimeter, or if it's a microscopically positive margins, and thyroid post-operative unstimulated thyroid levels in the range of 5 to 10 nanogram per ml. So what do you mean by post-operative unstimulated thyroglobulin? Can someone answer that? What do you mean by post-ablative thyroglobulin?
Sir, which is
Unstimulated thyroglobulin. Yeah.
obtained 6 to 12 weeks after the surgery, after total
Yeah.
thyroidectomy.
So what is unstimulated thyroglobulin?
Don't know, sir.
Okay, so after thyroidectomy, you're just supposed to check for you're not you're giving the patient levothyroxine. Okay, and you are checking for the patient, if the patient is they're checking the thyroid stimulating hormone, the thyroglobulin, or if the patient is having any antibody to thyroglobulin. So if the patient is not having any antibody to thyroglobulin, and the thyroglobulin level is less than 1 nanogram per ml, and there is a negative neck ultrasound, so in those kind of patients, you can completely avoid going for any RAI therapy. Unstimulated thyroglobulin means you're not giving any recombinant human thyroid stimulating hormone. So if unstimulated thyroglobulin is less than 1 nanogram per ml, you may go for a stimulated thyroglobulin, which is you are giving a recombinant human thyroid stimulating hormone, and then you are checking the thyroglobulin level. So even if after stimulating with a recombinant TSH, the thyroid globulin level is quite low, that means the patient is having a very less likely that the patient would have a recurrence. Am I clear on this? So as far as indication for RAT is concerned, like I have gone through a lot of guidelines. NCCN is very confusing. It gives us a lot of indications. The simplest one I found was the ESMO guideline. So you can note down the ESMO guideline. So RAI is recommended in all patients with known distant metastasis, one. Second, documented lymph node metastasis. Third, gross extrathyroid extension of the tumor, regardless of the tumor size. And fourth, primary tumor more than 2 centimeter, even in the absence of other high risk features. The high risk features being histological subtypes with tall cells, columnar, insular, and solid variant, as well as poorly differentiated thyroid carcinoma, follicular, and Hürtel cell cancer. So these are the high risk features. Not necessary to remember here. Just remember that irrespective of the high risk features, if the primary tumor is more than 2 centimeter, you are supposed to go ahead with RAI according to the ESMO guidelines.
Excuse me, sir, can you please repeat the indications for RAI?
Yeah, so make 2 columns. RAI recommended, RAI is not recommended. Just in bracket mention that it's the ESMO guideline, and RAI is recommended in all patients with number 1 is known distant mets. Number 2 is documented lymph node metastasis. Number 3 is gross extrathyroid extension of the tumor regardless of the tumor size. And number 4 is more than 2 centimeter, irrespective of other high risk features. Right? Right? Do you want me to repeat?
Yes, sir.
You want me to repeat?
Yes, sir. Please repeat. Recommended.
So known distant mets, documented. So known distant mets, you can write lymph node positive. So documented lymph node metastasis, lymph node positive, extrathyroid extension, and more than 2 centimeters. These are the only 4, right? Distant mets, lymph node positive, extrathyroid extension, more than 2 centimeter.
More than 2 centimeters. Okay, thank you, sir.
Right. Yeah. 4 indications for RAI, where RAI is recommended. For RAI is not recommended in patients with unifocal less than 1 centimeter without any other high risk features. Unifocal less than 1 centimeter without any high risk features, and patients with multifocal, but all the foci are less than 1 centimeter without any other high risk features. So either unifocal or multifocal, but all foci should be less than 1 centimeter. RAI is not, and no high risk features. Then RAI is not indicated, right? What are the high risk features? Are you done? Can I move on?
Not recommended is unifocal less than 1 centimeter without any high risk, and multifocal, but all foci less than 1 centimeter without high risk features.
Without high risk features. Okay. So high risk features are
high risk histologies.
Yeah, so high risk histology subtypes, which you can just write in bracket: tall cell, columnar, insular, and solid variant, as well as poorly differentiated thyroid cancer, follicular, and Hürtel cell cancer. And second, intrathyroid vascular invasion. Last one is gross or microscopic multifocal disease. So these are the high risk features. Don't worry, if someone has missed, I will take a picture of it, and I'll be posting it in the group of this particular case, of this particular term.
Okay, sir. Thank you.
So these are the indications for RAI. Now, can you mention how to go ahead with RAI? First of all, why if it's just a question here. So if it's a metastatic disease. If it's a metastatic disease, so you have a person is having a confirmed metastatic thyroid cancer, would you still like to do a total thyroidectomy?
Yes, sir.
Why?
To follow up the patient, there should not be any residual thyroid disease.
Two?
There should not be any residual thyroid to follow up the patient in well-differentiated carcinoma.
Why? It's a metastatic, so it will. So the patient will have a residual thyroid disease.
So when RIA is given, it will be taken up by the thyroid tissue if it is not surgery is not done. The metastatic.
Right, right. So if there will be accumulation of, so if it's a, if there are gross if there is a gross disease left in the neck, and you are doing that is a contraindication of doing a remnant ablative therapy. So you won't be able to do a remnant ablative therapy if there is a gross large disease in the neck, because a huge amount of thyroid uptake will be there in the neck, and then that would have its own side effects, right? So if more iodine is getting accumulated, then there would be radiation exposure to the surrounding structures, and the side effect would be more. So you need to remove the thyroid gland to be able to give radioactive iodine, right? Is that concept clear?
No, yes, sir.
Yes, sir.
So okay, so what else next? How do you go ahead with doing an RAI, and what are the doses for radioactive iodine ablation?
So we'll give low iodine diet.
Yeah.
The diet should be low in iodine, that is less than equal to 50 microgram per day for 2 weeks before and 2 day after iodine 131 administration. Then so we'll stop all the thyroid hormone replacement for as long as it takes to raise the TSH level to more than 30 micro unit per ml by the day of iodine 131 administration.
Right.
And we'll also do urinary iodine measurement.
If the patient is having any other, so any other things that you would ask the patient not to take, any other medications other than L-troxing or levothyroxine, any other medications that should be
I
avoided?
will tell the patient not to take sour candy, lithium,
So any iodinated contrast
yes sir,
should be
yes sir,
avoided. Iodinated contrast
intravenous, yes sir,
should be
iodinated
avoided.
contrast.
Should be avoided over the period of 3 to 4 weeks. Other drugs like amiodarone should be avoided in the for 3 to 6 months. Any other topical iodine like betadine should also be avoided. Any other like Lugol's iodine and topical iodine should also be avoided, and any anti-thyroid medications like methimazole, carbimazole, these also should be avoided during when you are preparing for a radioactive iodine ablation. So low iodine diet, right? After that, what would be the so how would you decide on the dose? So this part you need not to learn in details, but some basics concepts you should have about radioactive iodine ablation, basic concepts of how much dose you would be giving, and so yeah. So what dose would you be using?
30, 150, 200.
So 30 to 50 in which cases? So you're supposed to divide it into
Yes, sir.
low risk,
Yes, sir.
standard risk, and high risk, right? You're supposed to divide it into low risk, standard risk, and high risk. So what are the low risk cases? If it's a T1B or T2 disease, less than 4 centimeter, clinically N0, in those cases, in absence of any other adverse pathologic features, or in any other laboratory or imaging features. So if it's a T1B or T2 disease, less than, that is 1 to 4 centimeter, C N0. So the dose for those kind of cases would be up to 50 millicurie. So 30 to 50 millicurie would be the dose in those cases, right? For it would be, we would go a bit high, up to 150 in case of standard risk. And so what is standard risk, if can anyone mention?
If it is a pathological T3B, or if there are more than 4 positive nodes, or if there is an extensive ENE, and if there is a positive margin, or the value of post-operative thyroglobulin is more than 1.
Yeah. So can you repeat?
So if it is a pathological T3B, if there are more than 4 positive nodes, extranodal extension that is not extensive, and so positive margin, and if the post-operative thyroglobulin level is more than 1 nanogram per ml.
Okay. Okay. So and for high risk,
If it is a pathological T4, and if there is an extensive extranodal extension, and if it is M1.
so which classification are you saying? This is according to which classification?
This is according to, sir, ATA and NCCN.
ATA and NCCN. Okay, so there are various risk stratification criteria. You can follow any of the same. So if there are intermediate risk, microscopic invasion of tumor into the perithyroid soft tissue at initial surgery, or if there is a cervical lymph node, this is ATA risk stratification. So cervical lymph node metastasis, or if there is iodine uptake outside the thyroid bed on the post therapeutic whole body scan, or tumor with an aggressive histology or vascular invasion. So these are the intermediate risk. And high risk, like you said, if it's an M1, so if there is a distant metastasis or macroscopic tumor invasion.
So can you please repeat?
So simplifying, if there is margin positive but no gross, like there is no gross residual, but there is a microscopic margin positive, right? So microscopic tumor invasion into the perithyroid microscopic margin, microscopically if it is margin positive, or like you said, extra thyroid soft tissue. So extracapsular extension basically. So microscopic invasion of tumor into the perithyroid soft tissue at the initial surgery. Second is cervical lymph node metastasis. Or
so the cervical, any number of lymph node, or is there any number?
Just cervical lymph node metastasis, N positive. If it's N positive, right, it becomes an intermediate risk.
Okay, sir.
So and if there is any aggressive histology. Don't worry, whatever noting down I'm making, whatever things I'm making you to note down, I would be posting all the tables after the class in the group. Okay, so don't worry, even if you have missed anything, I would be posting the tables after the class. So this is based on ATA classification. Based on ETA classification, there is no intermediate risk. There is very low risk, and high risk. And based on ATA classification, there is, so ATA is the American Thyroid Association, right? And ETA is the European Thyroid Association. So European Thyroid Association differentiates between, it doesn't have any intermediate risk category. It has very low risk, and high risk. And ATA gives low risk, intermediate risk, and high risk. And so for ATA classification, low risk is when there is no local or distant mets, all macroscopic tumor has been resected, no tumor invasion of locoregional tissue, or no aggressive histology, and if iodine 131 test was done after the surgery, there was no uptake outside the thyroid bed. So these are the low risk cases. If there is any uptake outside the thyroid bed, or if the tumor histology is aggressive, or if cervical lymph node positive comes out to be positive, or if there is microscopic extracapsular extension. So these category will be intermediate risk. High risk would be if there is a macroscopic tumor invasion, or in gross residual, or distant mets, or the thyroglobulin is out of proportion, as is out of the thyroglobulinemia is out of proportion to what is seen in the post-ablative scan. So I'm sorry, even if in a post-ablative scan you don't see any residual disease, but the thyroglobulin level is quite high. So in those cases would be at the high risk. So
Please post risks in the group, sir.
yes, I'll be posting the risk. So the basic funda is that if there is a very low risk small disease, if there is a very low risk small disease, and there is, and the disease is T1 within the range of T1 N0 M0, and there is no so for those cases, remnant ablation would be done with using a dose of 50 millicurie, right? But if it is standard risk, then you would be going up to 150 millicurie. And if it is high risk, so a high risk would be if it is stage 4 or metastatic or gross node or margin positive. So gross node, margin positive, metastatic, stage 4 or T4, there you would go ahead with the dose of 200 millicurie, right? Any confusion? Not able to share my screen. I don't know why. Otherwise, I would have just, if you can give me some time, I'll just log out and log in. And I would try sharing the screen once again.
Okay, sir.
Okay, I'm still not able to do it. I'm sorry. So I would just go ahead with. Am I audible now?
Yes, sir. Audible.
Yes, sir.
Yeah. So the dose, like someone, Doctor, yeah, like Dr. Bhupen Prasad pointed out, the dose, it's right. Low dose 30 to 50, standard risk 150 millicurie, and high risk you go up to 200 millicurie. And so the low risk would be limited to T1 disease, high risk would be T4 metastatic disease, or gross node positive, or gross margin positive. And after that, for like so this is in case of de novo. So all the patients who have not received any prior iodine therapy, this is the dose. If the patient has received at least one iodine 131 therapy, for them, in case of standard risk, that is elevated thyroglobulin only and no visible disease, for them you can go give extra 150 millicurie. And for high risk, and for like this is here the standard risk and high risk is different. Just keep in mind, this is, I'm talking about the patients who have already received one dose of iodine 131. So for them, standard risk is patients with having elevated thyroglobulin only but no visible disease, and high risk would be if there is a positive margin or distance met, so if there is a visible disease. So for them, for the standard risk where only the thyroglobulin is raised but no visible disease, you would go ahead with 150 millicurie. And for high risk disease where you can see a visible disease, you give an extra 200 millicurie, right? And how would you call if the ablation has been successful? If 1 year post ablation there is no focal uptake, the neck uptake is less than 1%, and uh, the stimulated thyroglobulin should be less than 2 nanogram per ml. So stimulated thyroglobulin is again when you give uh, recombinant human TSH. So you give externally, you give TSH, and then you check for thyroglobulin. And if the check for thyroglobulin, if the stimulated thyroglobulin is less than 2 nanogram per ml, that is something that you would call as a successful ablation, right?
So can you please repeat the dose for already received one dose of iodine 1?
So standard risk 150, high risk 200. Standard risk is only when thyroglobulin is raised, no visible disease, and high risk is when you can see a visible disease. So if there is a recurrence that you can see in a thyroid scan, visible recurrence on a thyroid scan, you would go give 200 millicurie, and if there are no visible disease, only elevated thyroglobulin, then you give 150.
Thank you, sir.
So can someone tell me what are the side effects of what are the complications of doing an radioactive iodine ablation?
Swelling of the salivary glands or neck. There can be taste change. So there can be nausea.
Hmm.
Then there can be decrease in saliva and tears. There can be dry mouth, dry eyes,
Okay, so here
and
at this you should always remember, you're correct. Your answer is excellent and you're completely correct. But whenever someone is asking you about side effects or complications, right, you should always, like,
temporary and permanent.
rather than temporary and permanent,
Something chronic.
you should mention
Acute
the
and chronic.
acute and late
Late.
complication, right? Even for uh, especially for as far as radiation is concerned, So you should always mention early complications and late complications. So whatever you said are the early complications. So early complications would include, early side effects would include fatigue, headache, nausea, vomiting. Other than that, there can be, if there is a large remnant mass in the neck, then there can be radiation thyroiditis. Patients can have dysphagia or voice change. There can be, so if there is a residual thyroid gland, there can be transient hyperthyroidism due to release of stored thyroid hormone. There can be cytopenia, blood counts will go down. Sialadenitis can happen because it will be saliva in the salivary glands. There will be uptake, and RAI will be secreted in the saliva, and taste abnormality, like you said. And what are the late complications?
Reproductive dysfunctions, pulmonary fibrosis, second malignancies can also be seen. Sperm counts, transient decrease in sperm counts.
Yes, so 50 to 100 millicurie, if you have given, that would cause a transient decrease in sperm count. So that would ultimately result in a reproductive dysfunction. Pulmonary fibrosis, correctly mentioned. Secondary malignancy, there is always a 30% risk of secondary malignancy, because these patients, they like thyroid cancer is a cancer with a very good prognosis. So patients will live for long. Those patients who would live for long obviously would present with secondary malignancy owing to any kind of radiotherapeutic procedure, be it external beam or something of this sort. And how would you advise, what did you advise the patient to avoid any side effects?
Salivary stimulants to increase salivary flow. Basically, these are for the acute complications. And good hydration for renal clearance of the byproducts.
Right. And also remember, you should ask the patient to administer you should administer in an empty stomach, because there would be a decreased binding to the food, and if it binds to the food, the dose to the what would happen if you give this to the patient in a full stomach?
The increased uptake in the gastric mucosa as well, because
Right. So it will be increased uptake in the gastric mucosa. So gastric mucosal toxicity will be higher. Okay. So moving ahead with so what next? Have I missed anything? What next would you like to add? Would anyone like to add anything? So moving ahead with
differentiate between iodine 131 scan. Please tell us something about the iodine 131 scan also. Technical aspects of iodine 131 scan, possible.
So yeah, iodine. So thyroid scan can be done using either iodine 131 or iodine 123, and technical aspect means what do you want to know? I'm not sure actually.
Is done the dose and all
For scanning purpose.
Yes, sir.
I'm not. I'm not sure. I need to. I'm not sure. So I'm not aware of all the details. These are done by the nuclear medicine specialist. Okay. So I'm not aware if there are any specific dose for doing a radioactive iodine. But all you need to know is that radioactive the diagnostic procedure can be done using either a iodine 131 or iodine 123. Both are used, and for the treatment for radioactive iodine ablation, you're supposed to use iodine 131. Anything else?
So maybe we can go through contraindications of the radioactive iodine therapy as well.
Contraindications as it?
I believe pregnancy and breastfeeding, they are absolute contraindications.
Yeah, right.
They are the
So
only two.
can you enlist the contraindications of iodine RAI ablations? Can you enlist them?
So absolute, I know pregnancy and breastfeeding, and taking from the toxic side effects we just discussed, I believe bone marrow depression might be a contraindication as well. And maybe if pulmonary function restriction is there.
Okay, so I'll tell you as much as I know. So breastfeeding patients, we need to wait for at least 3 to 6 months after the cessation of lactation, or until the prolactin serum prolactin level normalizes. Up until that, you cannot give iodine RAI therapy, and there should be, even if you are giving, even if the patient has a has an infant, you have to completely stop breastfeeding after iodine 123 or iodine 131 administration. So no breastfeeding is allowed, and uh, other cases where you should consider about giving iodine 131 administration would be patients with decreased GFR and end stage renal diseases, or patients who are undergoing hemodialysis. So for them, you should seriously consider about uh, giving iodine 131. So the special consideration to should be done to administer doses and timing with respect to, like, these are not absolute contraindications, but you need to take care of the timing with respect to dialysis, such that so that the like there is so there, so that your like the non-thyroid uptake of iodine 131 is the least. Okay. Also, in those cases, you would consider a multidisciplinary involvement, and so that the radiation safety is maintained. Also, if the women are like if she is desiring pregnancy, she should be counseled to wait for at least 6 months after iodine 131 therapy to attempt pregnancy, to avoid any adverse pregnancy outcomes. What are the adverse pregnancy outcomes that are likely to happen if the patient if the patient taking 131 gets pregnant? Can anyone answer? So fetal hypothyroidism can happen. Fetal hypothyroidism can happen because of the high level of iodine, and at the same time because of the radiation, there can be malformation in the baby, or increased risk of malignancy to the child. Or even if the dose is very high, even there can be intrauterine death of the fetus related to the radioactive iodine.
Yes, sir.
So for even if the dose is very high, we might even advise to the patient to wait for 1 year after RAI rather than 6 months. Okay. Anything
Yes.
else?
So that day, nuclear medicine studies we were about to talk, I believe. So
Yeah, so there are various nuclear medicine studies that are there. It's like the first one is like a
radioactive
uptake study, RAIU. You for that you use a
iodine 2 to
iodine 132, and the
122.
dose is 200 to 400 microcurie, and the counts are measured over a low neck, measured over low neck in a 2 to 24 hours after administration. And other studies are if diagnostic whole body scan, and a whole body scan you can use either 131 or 123, and there the entire body is imaged using a gamma camera. And other than that, you have the pre-treatment whole body scan. So again, you done using 131 iodine 131. Not sure of the dose, and it is same as the diagnostic is same as the diagnostic whole body scan. So the entire body is scanned using a gamma camera. And the other options are you also have a technetium 99 scan, and iodine 120 and iodine, other iodine thyroid scans. So that's it. I don't think we've left any. So basically, just asking you this basic question. So you have done a thyroid scan, right? And so you have a nodule in the thyroid, and you have done a thyroid scan. So you can. So what is the why do you need do thyroid scans? What is the idea of doing a thyroid scan?
So basically, to see whether the nodule is functional or not.
Yeah. So would you? So if the nodule is functional, so if it is hot, would your diagnosis be in favor of malignancy, or would your diagnosis be in favor of malignancy if it is cold?
So if it is cold, then more in favor of malignancy.
Right. So if it if it is cold, then that is more in favor of malignancy, not hot. If it is hot, if it's a functional, then there are functional cells that are producing thyroid, and that is mostly because out of a benign disease rather than a malignant disease.
Yes, sir.
Okay, so moving on to medullary thyroid cancer, and just we'll shortly discuss about anaplastic thyroid cancer, and we would call it a day. So medullary thyroid cancer is basically the cancer of the medullary cells, which are these medullary cells are basically the interstitial cells. The papillary carcinoma and the follicular carcinoma, these are basically diseases of the of the functional cells of the thyroid. So follicular cells of the thyroid cancer gland, and in between these functional cells. So you know how thyroid used to look like back in the histology classes. So there used to be colloid inside, and then there's a surrounding lining, and in between those colloids and surrounding lining, there are the interstitial cells, which are known as the medullary cells. So the function of this cell is basically to secrete calcitonin. So thyroid arising from these parafollicular cells, parafollicular C cells producing calcitonin, would be the medullary thyroid cancer. And how would you treat a medullary thyroid cancer?
Total thyroidectomy.
And followed by?
Neck dissection.
What all levels would you dissect? Okay, just in the same note of, I think I missed this point. So about neck dissection, so neck dissection, NCCN guideline says about neck dissection, it says that you are supposed to do a central, so forget about medullary thyroid cancer, we are going back to the differentiated thyroid carcinoma, that is follicular or papillary. So NCCN guideline says that you are supposed to do a central neck dissection irrespective of anything, if you're suspecting a benign disease, along with the total thyroidectomy, you're also supposed to do a central neck dissection, and you need to see if there are if the lateral neck is involved or not. If there is any suspicious node in the lateral neck, you're supposed to do an FNAC. If it comes out to be positive, you're also supposed to do a lateral neck dissection. Other than that, prophylactically, only central neck dissection is good enough. However, in the ESMO guideline, as much as I could understand, the ESMO guideline does not recommend any neck dissection, prophylactic neck dissection, unless and until there is a positive, clinically positive lymph node. So don't confuse between that, between two guidelines. You can read any of the guidelines, and just need to know which guideline you are answering from. But just to understand, NCCN says you're supposed to do a central neck dissection, and if it's a high risk disease, if it's a quite big disease, or if the lateral neck seems to be involved with any node, then you can go ahead with lateral neck dissection also. But NCCN does advise for a prophylactic neck dissection, and ESMO, according to the ESMO guideline, if it's clinically N0, you're not supposed to do any prophylactic neck dissection. Neck dissection is to be done only when it is positive, as far as ESMO guideline is concerned. And as far as medullary thyroid carcinoma is concerned, you're right. You're supposed to do a total thyroid neck dissection with central neck dissection, and along with that, you may consider about doing an ipsilateral or bilateral 2 to 5 if the nodes are positive. And for a very high volume disease, you can do you're supposed to do a prophylactic neck dissection. So so what are the indications for doing an adjuvant Ebrt in a case of medullary thyroid carcinoma? If it's a completely resected disease, would you like to do an adjuvant Ebrt? What are the indications for adjuvant Ebrt after surgery?
So only if there is incomplete tumor resection, I believe.
So, okay, so note down there are 4 indications, as much as I could find out from all the books. So there are 4 indications of doing. This is only for medullary thyroid cancer. Okay, so 4 indications of doing an adjuvant Ebrt. So first one is margin positive. So if there is if there is incomplete resection, so if there is a residual disease or margin positive, like you said, right? If there are positive lymph nodes, if there is extensive extrathyroid extension, and the last one is persistent calcitonin even after doing a complete resection. Right? You want me to repeat that?
Got it, sir.
Yeah, margin positive, lymph node positive, extensive extrathyroid extension, and persistent calcitonin after a complete resection. So, is there any role of radioactive iodine here?
No.
No.
So treatment would be just Ebrt, and if there are if there is a metastatic disease, then there are other options like palliative local control, or palliative surgery, or palliative external beam therapy for metastatic diseases. And for systemic diseases, there are various systemic therapies that would include vandetanib, cabozantinib, and other kinase inhibitors. And okay, so I don't think I've missed anything in medullary thyroid cancer. Should we just move ahead with anaplastic
Yes, sir.
thyroid cancer?
Yes, sir.
Okay. So is it a good prognostic disease if the person is having an anaplastic thyroid cancer?
It's a
It's a
aggressive.
Poor prognosis, sir.
It's a worse prognosis. Anaplastic thyroid cancer is the most aggressive thyroid tumor, and it is one of the most aggressive cancers in human, right? So anaplastic thyroid cancer, there uh, like there are no specific guidelines as such, as far as like there is no standard of treatment for anaplastic thyroid cancer, and as because there are no efficient treatment as such, right? But you would still go ahead with the surgery. You would still go ahead with the surgery, or you would do a combination therapy of surgery, chemotherapy, or radiotherapy in case of anaplastic thyroid cancer. So surgery is indicated for local control in resectable lesions. So and there are various chemotherapeutic options also that are available for anaplastic carcinoma. So the agent that works most in case of anaplastic cancer is doxorubicin alone, or it can be given with a combination of cisplatin. But even with that, the results are not results are quite disappointing. And other chemotherapy that can be given are paclitaxel and bleomycin. Okay, so cisplatin, paclitaxel, doxorubicin, bleomycin with various combinations are the treatment that can be given. Some and targeted therapies were also tried, like sorafenib and axitinib. And other than that, some VEGF inhibitors were also tried, like bevacizumab and cetuximab. So that's it. That I think that covers as the thyroid as much as treatment is concerned. There are some other points that can be discussed about Ebrt, since we are mentioning we are studying it, so we can the dosage of Ebrt and other things can also be discussed. I'll just briefly touch the topic. So simulation for RT technique, simulation would be done. Simulation is done in a patient in a supine position, just like any other head and neck cancers. Simulation CT scan to be done, a contrast enhanced CT scan to be done. You wouldn't use contrast if you're planning to give an RAI. So CT scan to be done, and IMRT is a preferred technique. Doses, you would go ahead with the dose of 66 to 70 gray if there is a unresectable disease, or if it's a gross residual or positive margin. Other than that, you can or else for medullary thyroid carcinoma, you can go up to 60. Like for other indications, you may go up to 60 gray. That's what Paresh says, 60 to 66 gray. But if there is a gross residual, you have to go up to from 66 to 70 gray.
Can you please
And
repeat?
so if there's an unresectable gross disease, it's just like it is just like a normal head and neck cancer. Okay, so if there are microscopic residuals, you would go up to 60 to 66, and if there are gross residual, you would go from 66 to 70. That is the basic funda. So gross residual unresectable disease 66 to 70. If there is a microscopic residual, then you would go for 60 to 66. Right? That's it. In case of anaplastic cancer, like we were talking about it, in a case of anaplastic thyroid cancer, you may use the standard fractionation that I just mentioned, but most of the cases, anaplastic cancers, they are very aggressive. So most of the cases you would just use a hypofractionated. You may use like in a palliative case, you can use just a palliative hypofractionated dose schedule. Other than that, you can if you want to give a curative treatment, your doses may be the same. You can also try other accelerated or hyperfractionated schedules also, but mostly conventional treatment for anaplastic cancer would have a similar dose pattern, 66 to 70 gray. Or if it's a very aggressive disease and you are just giving the treatment for symptom palliation, you can give like 20 in 5 or 30 in 10 dose fractionation also.
Sir, Ebrt portals?
So for Ebrt portal, I'm not sure about the Ebrt portal. As far as, because you would do an IMRT in this case, I don't know. Obviously, you would give a lateral beam only, and not sure about the conventional Ebrt portals, but you would like to do an IMRT in this case.
So can you please tell the indications for Ebrt?
So indications for Ebrt for medullary thyroid cancers would be a positive margin, positive lymph node, extrathyroid extension, and a persistent calcitonin. For a normal differentiated thyroid cancer, the consideration would be if it is inoperable disease. So there you would like to go for an upfront Ebrt. So if it's an inoperable unresectable disease, or if it's a resectable disease, you would like to do the resection first, and then if you find out that there are residual residual tumor in the neck, then you need to resect the residual tumor. Even if even if you're not even able to resect, so that if the residual disease itself is also inoperable, then you have to go ahead with an adjuvant Ebrt. So for that, the indication would be any 45 patient who are more than 45-year-old with gross extrathyroid extension and high risk of having microscopic disease. Other indications for doing Ebrt would be non-iodine avid cancers, which I mentioned, like medullary thyroid cancer and anaplastic cancers, or patients with any gross extracapsular extension. So basically, if there is a residual disease in the neck, you're supposed to do RT in case of differentiated. Am I clear, or did I just confuse you again?
No, sir. Yes.
So if any residual disease, you're supposed to do an Ebrt.
Okay, sir.
Okay. Anything else, or should we call it a day? It's already 9:42. Any other questions at this point?
Sir, in the chat, there are 4 indications for FNA.
Indications for, one second. Can someone please repeat what is the 4 indication for FNAC in case of less than 1 centimeter in USG neck? So 4 indications. So if it is more than 1 centimeter, irrespective of everything, you're supposed to do an FNAC. If it is less than 1 centimeter, then there are some indications where you would like to go ahead with FNAC. These are, first of all, if there is a history of head and neck irradiation in the past, number 1. So history prior RT. Second one is a family history of thyroid cancer. Third one is a suspicious features at palpation. For if you find a very hard a hard lesion on palpation, that would raise a suspicion of any kind of a malignant disease over a benign one, and a presence of a cervical adenopathy, any lymph node metastasis. Right? Any other doubt? Dr. Chandrasekhar, can you please explain Bethesda classification? Can someone tell me what is the Bethesda classification? Can you tell me what are can you tell me what are like in which cases is it like what is the classification based on? So basically, it is like Bethesda classification is when you're doing an FNSE, so there on based on various criteria, you can classify the FNSE findings into from 1 to 6. So one is non-diagnostic and unsatisfactory, where you would like the ask the doctor to repeat the FNSE. And Bethesda so Bethesda 2 is if it is benign. Bethesda 3 is when it's a follicular lesion of unknown significance. 4 is follicular neoplasm or suspicious for a follicular neoplasm. Bethesda 5 is suspicious malignancy, and 6 is a confirmed malignancy. So Bethesda classification is done based on the FNSE findings, and that leads to the further decision making on the further course of action. So for Bethesda 1, 2, or 3, you would if the lesion is very small, you would like to just observe the case. For Bethesda 4 or 5, you would go ahead and do maybe a partial lobectomy or something, or complete lobectomy. Sorry, a complete thyroidectomy, or you can go ahead with a partial thyroidectomy like a lobectomy or isthmusectomy. And if it's a Bethesda 6, which is malignant, then you are supposed to go for a total thyroidectomy. Clear? Any other question?
No, sir.
Can you repeat the indication for adjuvant Vrt in a differentiated thyroid cancer? Adjuvant Vrt, if there is an extrathyroid extension, as simple as that. Okay, while you have removed the tumor, there are residual disease in the neck, and you cannot. You would ideally like to go ahead and remove the residual disease in the neck. If you cannot remove the residual disease in the neck, you go ahead and do a radiation. As simple as that. Not confusing. Okay. If you haven't resected it completely, you would try to resect it completely. If you can't resect it completely, you go ahead and do a radiation. This is for differentiated thyroid cancer. Indications are different for a medullary thyroid cancer. Done, right? Any other questions? Should I end the session?
Yes, sir.
Okay. Good night, everyone.
Sir, if
Good
we
night.
have a recording of
Thank you,
previous session, we
sir.
can
Good
share it,
night.
sir.
Pardon?
Sir, previous session of thyroid, if you have recording, so we can share it on group.
No, I did not record it. Someone else recorded it. Someone did record it as far as I remember, but I did not record it. I have recording of this session. I'll be sharing it shortly.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Bye bye. Good night. Hope the discussion was fruitful. Bye bye.
Bye.
Sir, please put the charts on group, sir. Risk.
Charts. Yes. I'll do that. Okay. Thank you. Bye bye.
Thank you, sir.